Welcome, everyone. We are glad you're here. I am Kelly Chapman. I am the Senior Program Coordinator here at the Southeast Mental Health Technology Transfer Center School Mental Health Initiative. We're excited to have you for part one of our series on Medicaid policy and school mental health. We hope that you will join us again for part two on December 13th at the same time. Some of you are already doing this, but we encourage you to introduce yourself in the chat. Let us know your name, your role, where you're joining us from. And if you have any technical difficulties during our presentation, we ask that you let us know in the chat and someone from our team will assist you. Also, if there are resources that you would like to share during the course of the presentation, put those in the chat as well. During the course of our presentation, we will share a link to a very brief survey in the chat later on. It's a two-part survey. We ask that you complete both parts. It gives us great feedback on what is helpful for you all. It's required by our funder and allows us to continue to do our work. I'd also like to highlight that at the end of the second part of the survey, you will have access to a certificate of attendance for today's session. Now we have a quick disclaimer before we get started. The Southeast Mental Health Technology Transfer Center Administrative Supplement is funded by Substance Abuse and Mental Health Services Administration, SAMHSA. The opinions expressed herein are the views of the presenters and do not reflect the official position of the Department of Health and Human Services, DHHS, SAMHSA. No official support or endorsement of DHHS, SAMHSA for the opinions described in this document is intended or should be inferred. Today's session is brought to you by the Southeast Mental Health Technology Transfer Center. We are located in Atlanta, Georgia at Emory University Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4, which you can see pictured on the slide here. Our center includes faculty and staff with expertise in public health programs, policy, finance, and health systems. And these expertise give us a unique lens through which we can address the mental health priorities in our region. The goal of our center is to accelerate the adoption of evidence-based practices for mental health programs and practices, by providing training and technical assistance to Region 4. And now I'm very happy to introduce our speaker, Dr. Adam Wilk. Dr. Wilk is a health economist and a health policy researcher at Emory University's Rollins School of Public Health and the Health Policy and Management Department. He has 17 years of experience in Medicaid consulting, technical assistance, and research. His research focuses on access to care for low-income and underserved populations, particularly those with chronic illnesses, and state financing and policy related to providers' operations and care. And now I'm going to turn it over to Dr. Wilk.
Thank you so much, Kelly. And thank you all for joining us. It's really a pleasure to be talking to you all today. We have an awful lot to talk about, so I'm going to dig right in. Our agenda for today, first I'm going to tell you what we're going to be learning today. And then I'm going to walk through some details on 2 major requirements for billing Medicaid for school mental health services. The first relates to the service. It has to be a covered service. And then the second has to do with the recipients, that they have to be enrolled in Medicaid. But there's a lot of nuance on that, so we'll have plenty of time to go through those details. And then I will leave a lot of time for Q&A. I'm looking forward to talking to you about your questions related to these issues before we conclude today. So as questions occur to you during the course of the presentation, please jot them down and hold on to them for when it's time for Q&A, and then you can throw them all in the chat at once. Once I figure out what's what, I can answer a few of those. All right. So for today, I'm hopeful by the end of this webinar, you'll be able to specify when Medicaid can be billed for school mental health services. That is, what are the major requirements and conditions? I hope you'll be able to discuss how Medicaid policies affect who may be eligible for coverage under Medicaid and what services may be covered by Medicaid. Those are the 2 requirements we'll focus on today. And then I hope you'll also be able to describe and distinguish 2 main pathways for reforming state Medicaid eligibility and service coverage policies in support of school mental health. There are opportunities there, and you want to be prepared to take them on. So for those of you who have been with the school mental health initiative here at the MHTTC for a while, you may have encountered our webinar on this topic in May with a very similar title. Our thinking was that it would be helpful to present a lot of the same material, but with more contemporary policy development discussions, as well as walking through the same material at a slower pace and in greater depth. So that's my aim for today. But if you're looking to share a version of this webinar that isn't a two-part version that maybe someone else can run with a little bit more quickly, we did cover a lot of the same material in the May webinar, and the recordings and slides for that presentation are available for download. All right, so here's our first poll question of the day. We're hoping to get a bit more information about you and your experiences working with Medicaid, so that we can make sure we're tailoring our programming to your needs. So I'm seeing poll number 2 here, Kelly. Do we have number 1 ready? Which would be about the amount of experience you have working with school mental health services and Medicaid to pay for it. There it is. Beautiful. Thank you. So please select the answer that best fits your experience. And then once we have that, I'll be able to see the summary. All right, Kelly, let me know when we've got a sufficient quorum of answers here. Beautiful. All right, so I'm seeing that nearly half of us have little or no experience working with Medicaid to pay for school mental health services. Fantastic. You're in the right place. I hope this is a very informative webinar for you. And then we have a healthy number of folks who have between maybe 1 month and 3 years experience. There's probably quite a lot to learn there too, as you've been learning. So I hope that this is helpful for you as well. There is enough depth here that I think those folks will also learn a lot. And then for those of you who have more experience, please chime in the chat with any best practices you've been thinking about as you've been learning the ropes. All right. So the last thing before we dig into the 4 requirements and the top 2 of them, our center produces a lot of resources related to Medicaid and school mental health services and the financing thereof. Probably our top resource in this vein is our Medicaid FAQs report. It synthesizes a lot of information from a variety of different resources to become sort of a one-stop shop for all things Medicaid financing of school mental health. I believe the link to this report is in the chat now. Thank you very much, team. I would strongly encourage you to check it out, download it, share it widely. Of course, it's free, just like all of our resources. And I'll be referring back to this report in a few periodically over the course of the presentation, highlighting ways in which it can be particularly useful and relevant for today's discussion. All right. So here's what you've all been waiting for, the 4 requirements that have to be met in order to bill Medicaid for school mental health services. All right, the first of them is relating to the service. That is, Medicaid has to cover the service. It has to be on the list of services Medicaid covers. Related to the recipient, the student or client has to be enrolled in Medicaid. Not good enough that they're eligible. They have to be actually enrolled, and that can be tricky. The third requirement pertains to the provider. The provider has to be a Medicaid certified provider. And then the setting is important too. The school has to be a Medicaid accepted setting for that particular service. So today, we're going to be talking about the first 2, the top 2 of these requirements. And we've saved the 3rd and 4th for our December 13th part 2 segment of this webinar series. So please do come back for that. But again, today, we're going to be focusing on the top 2 and starting with the service. Medicaid has to cover the service in order for Medicaid to pay for it. That seems kind of obvious, but there are, of course, devils in the details. So let's look at those. Medicaid can pay for both direct services and some associated expenses of administrative services. Some people don't know about the administrative services part, and I'll come back to that in a moment. But first, the direct services, which include both mandatory services that the federal government requires every Medicaid program to cover, and optional services that not every state covers. The set of mandatory services is pretty broad. It includes EPSDT, which is the Early and Periodic Screening, Diagnostic, and Treatment Benefit. It's a mouthful, and I'll come back to that in a moment. In addition, Medicaid is required to cover physician and nurse practitioner services, rural health clinic and FQHC or federally qualified health center services, and transportation to medical services, all very relevant to behavioral health in school settings. But then there are other services that you might be surprised to learn not every Medicaid program covers, despite their importance to many populations we care about, including things like prescription drugs. Psychotropic medication is not always covered. Telehealth and telemedicine, not always covered, nor are case management, inpatient psychiatric services for youth, and HCBS, home and community-based services. So, of course, it's very important to know which services are covered in your state and which are not. If it's on the mandatory list, you can take it for granted. If it's on the optional list, you can't. Now, I'll be showing you in a little bit how to identify which services are covered in your state with some examples. But first, I want to go back to administrative services for a moment. Again, not everyone appreciates that Medicaid can, in fact, pay for some administrative services related to school mental health programming. In particular, certain administrative supports for direct services, as well as outreach and enrollment services. Now, if you're really interested in this, I would strongly encourage you to check out this report, which is a guide released by the Centers for Medicare and Medicaid Services. That's the federal agency that oversees the Medicaid programs across the country and partners with states in administering them. It is a guide that has been long awaited. It's the first time in 20 years that CMS has released a report that describes in a lot of detail all the ins and outs of how to bill Medicaid for administrative services, including lots that are relevant for our school mental health programs. And so just to further impress upon you the importance of this guide, I pulled a quote which reads, "CMS strived to include every school-based services policy and mechanism to allow states and LEAs the greatest flexibilities as far as implementing and expanding school-based services." Wow. They really want to improve access to school-based services and want to make Medicaid a useful tool in financing them. And so this report reflects that. It's very comprehensive. And I find it very useful, very much relative to what people had to use previously, which was this antiquated 2003 report. So please do click the link to this in the slides when you download them from our website. You'll get links to that in your emails forthcoming. All right, but back to the main requirement that Medicaid has to cover the service. I mentioned that not all services are covered in all states. That is a major source of variation in Medicaid across states. Different states cover different services. So where do you look? For your state, the best resource is your own state Medicaid program's website. And that website will usually have a section listing covered services or Medicaid benefits, or use similar language like that. Sometimes that's on the patient or beneficiary facing side of the website, which most of the websites are catering to first. But sometimes that you may have to look in a provider facing section because that information is certainly very relevant to providers as well. But it's always up there somewhere. So keep digging. I promise you'll find it. I'll show some examples in a minute. Now, the fine print here. Some services may be covered only with certain circumstances and conditions met. So first, certain services may be billed and paid for only with certain diagnosis codes listed. So for example, in some states, it might be that group therapy services are only billable if you also include on your claims certain diagnoses for depression or anxiety and maybe little else. So if you don't have those listed for the individuals who were receiving the service, you can just take it for granted the claim will be rejected. So you got to know which diagnosis codes have to be included. I know some providers have built templates that automatically include the diagnosis codes that are relevant for certain services on those claims when they're generating them. But of course, you can only use those if the individuals for whom you're providing the services have those diagnosis codes and meet those diagnostic criteria. But there is sometimes a caveat there. You have to include the relevant diagnosis code. Another relevant caveat in the context of Medicaid managed care is prior authorization. Now, Medicaid managed care is the term used to describe the private plan administration of Medicaid benefits on behalf of the state or under contract with the state. You may have heard of managed care organizations or care management organizations. They may impose a handful of different requirements that add wrinkles into the process of billing Medicaid. I'm not going to talk a lot about those today. We're going to talk more about those on December 13th, but there is one MMC related requirement that I wanted to talk about today, and that is prior authorization. Certain services may only be paid for if before you render them and bill for them, the Medicaid managed care organization has given authorization for that service. That's the prior authorization requirement. So it's important, of course, to know what requirements your Medicaid managed care plans impose for these services so that you're ready to meet them in advance of services. So build good relationships with those managed care organizations. They have important info for you. All right, so I promised a couple examples of where to look. These are screen caps from the first Florida Medicaid program website. They have a page conveniently called Florida Medicaid's Covered Services and Home and Community-Based Services Waivers. They have a little extra information on there, but this is definitely the page you want to find for Florida to identify what services are covered. If you're in South Carolina, their website encourages you to download a PDF of the Medicaid Member Handbook, which is the document that includes the updated list of covered services. So if you're looking for something on the website itself, you might be disappointed. You have to know you have to dig into a PDF. It may be a little less intuitive in some ways. Also, if you're working with providers partnered in the community, they may not recognize that they have to look on the patient-facing side of the website for the member handbook to find this list of covered services. So a little bit of nuance in every state. That's what Medicaid's good for. All right, so I mentioned a few caveats that may restrict coverage of services in some contexts. Some of you may be under the impression that school mental health services are covered only for youth with an individualized education plan, an IEP. That is for individuals who are eligible for supports under the Individuals with Disabilities Education Act, or IDEA, and have an IEP. Well, it turns out that that is true only in some places and only in limited circumstances. So for the most part, I want you to recognize that it's a myth. So Medicaid certainly will cover the school-based medical and behavioral health services specified in a student's IEP. Absolutely. Of course, so long as those services already meet standard requirements for Medicaid reimbursement, like, for example, that the provider is a Medicaid certified provider, something like that. But whether the Medicaid program in your state will cover the same services provided in schools for students without an IEP depends on whether the state has implemented the current guidance under the so-called free care rule. Now, when I say current, the latest guidance for the free care rule has been in place since late 2014, but not all states have yet implemented this new guidance under the free care rule from 2014. And may have done so, but only for certain services like physical health services, but not behavioral health. So if you're in one of those states, maybe it is true that students have to have an IEP in order for behavioral health services to be covered when provided in schools. But in increasing numbers of states, you don't have to have an IEP for Medicaid to cover services, school mental health services. Just tune in to the December 13th webinar where we will talk in more detail about the free care rule and the latest on those developments. All right, so now I'm going to take a deeper, closer look at two types of services that Medicaid does, and in one case may cover. We're going to start with EPSDT here. Again, this is the Early and Periodic Screening, Diagnostic, and Treatment benefit. This is a mandatory benefit. The federal government requires all Medicaid programs to cover this set of services for all enrollees under age 21. And it's a pretty rich benefit. It covers many different screenings, diagnostic services, and treatments, the full lists of which we include in one of our resources on the website. The link is here. Among the school mental health services relevant to our context that EPSDT covers are things like autism screening, depression screening, and assessments for tobacco, alcohol, and drug use, as well as many other screenings for optical care, dental, and many other things. Now, the real kicker for EPSDT is that Medicaid has to cover all diagnostic and treatment services that are needed to treat the conditions identified through an EPSDT covered screening. So, suppose a service is on the optional list. Medicaid doesn't have to cover it, and in your state, it doesn't cover it. Now, if an individual is identified as having a need for that service through an EPSDT covered screening, that is overruled. Medicaid will then pay for the diagnostic and treatment services for that EPSDT identified need, even if it's not in the otherwise on the list of services Medicaid will cover. That's a really generous benefit. It's a really rich benefit, and yet it is often underutilized. So there are many reasons for that, but our center is of the opinion that it is significantly because of the mental health workforce shortages that many of our communities are dealing with. I can't see very many of your faces right now, but I trust many of you are nodding. We all appreciate that in many communities, we are short of mental health providers. There's no question about it. Now, that might mean that some LEAs would choose not to implement many EPSDT screening services just because they believe it's not worth it. What's the point of identifying a need for an individual if we won't have any providers to refer them to where they can get those needs met, right? We can reallocate those resources and make better use of folks' time. Well, our opinion is that that may actually inadvertently contribute to the mental health workforce shortages because if we don't do the screenings, we don't know how much need there is. And so then we don't know how much money to allocate to improving the mental health workforce shortages in communities where need is high. So anyway, if you're interested in this cycle, we have another resource on our website now, conveniently titled, "Why is the EPSDT Medicaid benefit underutilized in financing school-based mental health services?" Feel free to click that link and engage with your state in finding ways to improve use of EPSDT and maybe address the mental health workforce shortages in tandem. So there are some efforts going on in some states to try and improve use of EPSDT services, maybe in your state too. Here in the Southeast region, one example is Alabama, where in the fall of 2021, the state sponsored or endorsed a partnership between 8 county LEAs and a community mental health organization to expand provision of EPSDT preventive mental health services in schools. Now, from our perspective, this looks like a fabulous arrangement and makes a lot of sense. In communities where this community mental health organization operates, they've reached a partnership where they can go into schools and provide some of these screenings and other preventive services under the EPSDT benefit. And of course, because they are a community mental health organization, they have some capacity to meet many of the needs that would be identified through those screenings, right? Schools don't have to worry about where to refer them after that. And then even sweeter, if the community mental health organization doesn't have capacity to meet the needs of those students, they're in a good position to know who to refer these students to. They can help with those connections and facilitate telehealth and other things. So we're very excited by this partnership arrangement and hope to see more of those in other states. And yet many states still do struggle in many ways with EPSDT. And this was reflected in an initiative launched by the National Governors Association earlier this year. At a conference where they convened, they recognized these ongoing struggles and then also issued a document that lists several proposals to expand the mental health workforce in ways that could advance the use of EPSDT. So again, there's a great link in this slide here when you download the slides to go to that National Governors Association initiative and learn what kinds of opportunities you may have in your state to expand the mental health workforce and maybe expand EPSDT use. All right, so that's enough for EPSDT for now. I'm going to shift gears to talk about telehealth, but before I do, I want to give you some insights into how to reform Medicaid programs in ways that are particularly relevant for the evolving telehealth coverage landscape right now. So the first of these opportunities to reform Medicaid is through something called a state plan amendment, or SPA. Yes, we do call them SPAs. So first, you need to know what a state plan is. The state plan is basically a contract or agreement between the state and CMS, the federal government, about how the state is going to administer its Medicaid program in compliance with federal requirements. Now, this contract, this agreement, can be amended with approval from the federal government. So the state has to submit a proposal for every one of these things they want to change. But when that approval is given, states can change a great many things within federal guidelines through SPAs. They can change which services are covered. They can change which rules, they can change rules that determine Medicaid eligibility, which is a big topic we're going to come to in a few slides. And also the reimbursement rules or payment levels for many services can be changed through SPAs. So it's a pretty powerful mechanism for changing many components, important components of Medicaid programs. But not all things can be changed with SPAs. You do have to do things within federal guidelines with SPAs, whereas Medicaid waivers don't have the same restriction. Medicaid waivers allow you, again, with approval from the federal government, to deviate from federal Medicaid requirements and explore innovative program designs. You can bend the rules here. Now, the federal government will only approve of proposals to bend the rules if the proposal is cost neutral, that is, it's projected not to increase spending for the state or the federal government, and it meets certain other requirements. But with those restrictions in place, it is a potentially very powerful mechanism for changing how Medicaid works in your state. So SPAs and Medicaid waivers together represent two of the 4 or 5 different major mechanisms through which Medicaid can be reformed to improve access to telehealth services or change many other things. Others include legislation or regulatory changes, but all of these different types of reforms are covered again in our Medicaid FAQs report. There's a section of it highlighted here and screen capped. Again, please refer to the link in the chat if you're interested in downloading our FAQs report. The final section of the report covers Medicaid reforms and how to advance school mental health service access through those reforms in your state. All right, so I mentioned telehealth certainly is one of those ways, one of those service types that can be expanded in your state using these kinds of reforms. I'm going to take a step back to level set with everyone about what I'm talking about here with respect to telehealth and telemental health. This is an optional benefit. Not all states cover telehealth or telemental health services for Medicaid beneficiaries. And it is certainly an opportunity to extend the mental health provider workforce in your state, right? You can get access to someone who's farther away, easy peasy. Now, states may vary in their requirements or coverage terms for telehealth in many different ways. Some of them include whether they're reimbursed under Medicaid or whether they're reimbursed under other payers as well, including commercial insurers if you're partnering with them. And there may be other professional requirements as well. Maybe certain provider types are eligible to bill for telehealth services while others might not be. And then, of course, there are different types of telehealth services for which coverage terms may differ within a single state. Now, with all of those different types of variances in state policy related to telehealth, it's important to keep track of those things in your state. And thankfully, you don't have to do that because someone else already has. I'm really grateful to the Center for Connected Health Policy for doing a great job of tracking this information and disseminating that information as often as twice annually. I think they're moving to annually moving forward. Now that we're a little bit further removed from the public health emergency of the COVID-19 pandemic, it doesn't need to happen as often, but they've prepared several resources summarizing information on state telehealth laws and Medicaid program policies for your state and your neighbors. And they've summarized that information in many different ways that are very useful for different contexts. I think it's really a great resource and props to them for putting together all of this stuff. Now, if you're interested in getting into the deep nuts and bolts of implementing telemental health services in your schools, the best place to look, I think, would be some of our peer MHTTCs in other regions. From the Mountain Plains region and a few other regions, they've spent a lot of time and energy figuring out how to do this and giving guidance on it. So please do check out their resources as well. But again, if you're interested in the policy side, which is more of our focus here today, check out the link in the chat to the CCHP resources. All right, so I pulled some data from their report just to give you a sense as to how much variation there really is in Medicaid policies related to telehealth coverage, just for our Southeast region to illustrate. So I mentioned there are different types of telehealth services for which there may or may not be coverage in your state. There are also certain states, many states, I think 17 at this point, that have some originating site restrictions. That is, if the patient or client receiving the service is in a particular location, like their home or at school, certain states restrict whether that service is reimbursable. And half the states in the Southeast region have such restrictions, which may include, again, with respect to schools. Across all 5 of these columns, you see there's a lot of differences across states in telehealth coverage terms. And in fact, across the 8 states in our region, no 2 states have the exact same telehealth coverage terms. It's kind of crazy. Just looking at these 5 requirements, no 2 states are alike. So again, check out the CCHP report and find out what's going on in your state. It has also been an area of rapid development and evolution in policy, again, because of the COVID-19 pandemic. It was a significant catalyst for expansion of telehealth coverage in Medicaid, including specifically for behavioral health services. So now at this point, nearly all states have allowed or expanded audio-only delivery of Medicaid behavioral health services, for example, as well as many other types of telehealth services. So as this continues to evolve, it's worth continuing to monitor, certainly. One area in which there has been continual development is with respect to payment parity. So it is often something that many providers have griped about in many states for years, where if the same service was delivered in person versus via telehealth, they could expect to be paid a different amount. Now, the costs associated with delivering services via telehealth might be lower, which I think was the reason for the payment differential, but it's still a disincentive if telehealth is paid less for providers to take on telehealth initiatives. So many states are moving towards parity in payment for telehealth and in on-site services. One example is a law passed in Tennessee earlier this year, which was mainly focused on instituting coverage for a new temporary mental health services benefit, primarily for people who are in crisis. Now, within that law, there was some language that expressed a mandate where telehealth services had to have the same pay rate as the same services provided in person. So not all pay equity policies have to be instituted by law, but this one is, and it's just an example of how states are moving in the direction of payment parity for telehealth. So if your state has not moved in that direction, there are plenty of examples to look to across the country for moving in that direction. And most of them, by the way, can be implemented. Most of these payment changes can be implemented via state plan amendment, as I talked about earlier. Those are relatively straightforward. And again, there's plenty of examples, including on a national website. If you just Google or Bing state plan amendments Medicaid, the top listing is almost certainly going to be the federal government website that includes all of the state plan amendments for your state and every other. And you can, filter them and search through them. It's a very handy resource for advancing the ball on these things. All right, so I'm going to pause from my yakking here for a moment to do our second poll question. So I want to learn a little bit more about some challenges and frustrations you may be having in your communities related to financing. So Kelly, if we can pull up that second poll question. Beautiful. So in your school-based mental health programs, which tier 3 services, which Medicaid often covers, are most challenging to finance in your experience? So if the tier 3 term is something you're not accustomed to using, we basically just mean one of the 4 options below. That includes things like individual therapy, group therapy, psychotropic medication management services and visits, and telemental health. So pick the item that has been most challenging for you or the one that stands out at the moment. And then we'll have a sense as to where folks are concerns are focused. Maybe that'll inform some future resources that we can develop here at the Southeast MHTTC. All right, Kelly, when we're ready with a quorum of answers. All right. Oh, we've got a really wide distribution here. This is great. All right. So I'm seeing 31% for individual therapy, 26% for group, 28% for psychotropic medication management visits. So this is really interesting. I wanted to point out that when we're talking about which services are challenging to finance, some people think the main reason is because that service isn't covered. Well, many of you who have been experiencing frustrations have probably noted that's not always the case. It's the conditions under which these things are covered that really is where you get got. Some of those conditions in particular that are most tricky for some of these services are the ones that we're going to be talking about in the December 13th part 2 portion of this webinar. So if you are experiencing frustrations with any of these, and perhaps multiple of them, again, I would encourage you to show up for our December 13th part 2 component. I bet you'll get some insights as to where things may be running aground. All right, so thank you again for that. I'm going to move ahead now to talk about the other requirement of our focus today, and that is related to the recipient. That is, the student or client has to be enrolled in Medicaid for Medicaid to cover the service. So the student client, just for reference, Medicaid is an entitlement program. You've probably heard that before. What that means is whoever meets the eligibility criteria for the program has the right to enroll. Now, the criteria include categorical criteria and income criteria. An individual has to belong to a particular eligibility group. And just like for services, there are mandatory categories and optional categories. So there are certain groups of individuals your state may or may not cover. And we'll come to some examples of that in a moment. Then within each of these categories, there are different income limits that must be met. That is, an individual's household income must be below the income limit in order to be eligible in that category. So the federal government establishes minimum household income limits for each eligibility category, but states can choose to set higher income limits and so extend coverage to more households that way. But clearly, this varies by state too. Not all eligibility categories are mandatory, and income limits at the federal level are minimums, so there's variation across states in covered populations and at what income levels. One example of an optional eligibility category that not all states cover is the so-called Katie Beckett waiver population. This is for children under age 19 with long-term disabilities or complex medical needs who receive an institutional level of care at home. So that is a distinct population from some other groups with high needs, and so some states have chosen to cover them in particular. The state Medicaid websites usually do have a pretty clear section describing eligibility criteria, usually on the patient-facing line. The fine print here, some individuals may be covered only with eligibility recertification with some frequency. That is, coverage is temporary. After a certain point, individuals have to recertify their eligibility in order to maintain coverage. Now, the policy around that has been changing an awful lot under the COVID-19 pandemic and recently, and I'm going to come to that in a moment. There's also some distinction to recognize between Medicaid and CHIP, the Children's Health Insurance Program. Some individuals may be covered, some individuals with higher household incomes, that is, may be only eligible for coverage under the CHIP program, but not Medicaid. So CHIP usually has higher income eligibility thresholds, And yet some people get confused between the two because in some states, the CHIP program has the same name as the Medicaid organization or is administered out of the same office building. And so it's not always clear which is which. It is important to recognize the difference, though, because if you're eligible for CHIP, there may be certain restrictions on coverage that you don't see in the Medicaid program. All right. So to just give you an illustration of some of the variation in these terms across states, here are the income eligibility limits for children across the 8 states in the Southeast region. You can see there's more than 100% of the federal poverty level difference in the income limits across states between Alabama and South Carolina. The federal poverty limit, by the way, is something like $36,000 for a family of 4. So just to give you a sense as to the magnitude of the difference here. Another resource highlights more information on that for the Southeast region. So the Medicaid website examples are usually pretty easy to find, again, for information on eligibility categories and income limits, because that's really the main purpose of these Medicaid websites, is to help individuals who may be eligible determine if they're eligible. The Georgia Medicaid website makes that pretty straightforward. In Kentucky, there's a little bit of an extra nuance because Kentucky has integrated its enrollment platforms for Medicaid and its state health insurance exchange for non-Medicaid enrollees. That's called Connect. So it is somewhat less straightforward to reach this page. And it's maybe a little bit more difficult for providers or LEAs to identify the eligibility criteria since they're lumped together across 2 programs, even though it may be more convenient to set up the website this way for beneficiaries. So that's why there may be some differences across states in what to look for. All right, so I mentioned the COVID-19 era rule changes. This has to do with eligibility recertification. Again, in many cases, states require individuals to recertify their eligibility fairly frequently in order to sustain their coverage. But under the COVID-19 public health emergency, states could not disenroll Medicaid beneficiaries, even if they were no longer eligible by the criteria. This is the so-called continuous enrollment provision of the PHE. Now, as of April 2023 and the end of the public health emergency, states could now resume disenrolling individuals who were no longer eligible. If you've been hearing about this in the popular press, it's sometimes referred to as unwinding the continuous enrollment provision. Now, the Kaiser Family Foundation has been tracking this change, and as of a week ago, they found that approximately 10 million individuals have been disenrolled from Medicaid over the last 6 months, including about 4 million children. Now, that's a lot of individuals, but I want to caveat that another 18 million have had their coverage renewed and sustained eligibility, just for reference. But still, it's a large bolus of individuals who are losing coverage at the same time and maybe experiencing frustration or confusion about this policy change because they gained coverage for the first time in the last few years. It's the first time they're going through this recertification process. Now, there are certain groups that are particularly at risk of disenrollment in this environment, including individuals with disabilities, individuals who have moved and so have had some of their information change, immigrants, individuals who speak English as a second language. If you have some of these communities in your neighborhood, you might want to watch out. They may have lost Medicaid eligibility and need some more supports and outreach to regain it. And of course, more disenrollment is expected too. As of October, only 5 states had processed renewals for at least half of their enrollees so far, and they may continue to proceed with this process into next year. Some states have expressed that they plan to do that. And in fact, there are lots of differences across states in how they are processing these recertification changes, in their timelines, in how they're reaching out to enrollees, what waivers they may be seeking to help provide additional supports to individuals. So there is a Kaiser Family Foundation letter from June of this year that lays out some of these variances. It may be worth getting to know what's going on in your state if you're interested in seeing some of these policies changed or enhanced for your beneficiaries. I did also want to highlight one other change. There was a law passed in 2022 that required by January of this coming year, so within a few months, all states will have implemented 12-month continuous eligibility for children. The goal here is to reduce this churn in enrollment where some people would lose and then regain Medicaid coverage every time they came up for re-enrollment, every 6 months or maybe more frequently. So now it's going to happen only every 12 months. Now, there will still be some children who lose coverage at annual enrollment time when it's time to re-demonstrate their eligibility for administrative reasons because they can't find the paperwork or what have you. There are options that Oregon has proceeded down the path of to extend continuous eligibility for even longer periods via waivers. So they have blazed a trail there that we can follow with their waivers and SPAs if you want to see continuous eligibility extended for children in this population. All right, so I'm about to wrap up, but I did see the GIPRA link in the chat. Please do remember that before the end of our webinar, we'd love for you to provide some feedback. It helps us with our funding and enhancing our programming. I do also want to highlight some additional resources about Medicaid and school mental health that our Southeast Mental Health Technology Transfer Center has produced. One, again, is this May webinar that I alluded to earlier, which is sort of the more rapid fire version of what I've been talking through today. The slides and webinar recording are available. And again, it includes, among the things it covers is some expanded discussion of mechanisms of Medicaid reforms. So if that is of interest to you, please check out the recording and slides. We also did a webinar last year that assumes little to no foreknowledge about Medicaid and how it interfaces with school mental health. We called it Medicaid and School Mental Health 101. Those slides and recording are also available for download, so you can check that out as well. And then our center has produced a number of additional relevant resources to our conversation today, including a guide through all of our Medicaid-related resources in webinar form. But then we've also produced a resource catalog that I really want to emphasize to you is your guide through all of the resources our center has provided and produced related to Medicaid and financing of school mental health, as well as many other important areas of school mental health systems. So check out the link, it's in the chat now. Download the resource catalog and please download and use all of these resources as can be helpful to you and your communities. All right, so I've been talking an awful lot. I hope you've been preparing some questions. I will be pulling up the chat now and can start to look through some of them. As I'm doing that, I'm going to take a drink of water and again, remind everyone that if you're inclined to leave before the end of the hour, please do check out our GIPRA link. And provide us some feedback. And I ought to give you an extra advisement that at the end of the first survey you see, which is the federally required one, we also have our own link to a Qualtrics survey, which asks a few more questions that we're particularly interested in using to help enhance our programming. So please do look out for that. It will automatically migrate you to the Qualtrics survey. So please complete that if you're interested in obtaining a certificate of attendance for your participation today. All right, I'm starting to see a few questions in the chat here. So one question that came from earlier, thank you, Josie, for bringing that to my attention. Would EPSDT include universal screening practices? Thank you for your question, Jen. Usually the answer to that question is no. I alluded to Tier 3 services earlier in the context of Poll 2. And usually universal screening practices would be captured under the header of Tier 1 services. And to my knowledge, there are no Medicaid programs across the country that cover universal screening programs. Those tend to be financed through other mechanisms, maybe through ESSA and other education-oriented funding mechanisms or local foundations or the like. That's where I would look for financing for that. Still, EPSDT is a very generous set of targeted screening services that are covered for individuals who are at risk. As well as I discussed earlier, services that those individuals with identified needs might need in the form of diagnostic or treatment services. All right, so another question from Michelle asks, how can local school systems receive the information provided? Well, so there's a lot of different types of information that we've made available through this webinar and our many other resources, certainly. I made reference to our resource catalog. We would certainly encourage you to share that resource catalog far and wide and let people know about us and the different resources available. I also made regular reference to the state Medicaid program's website, which is a great starting point, even if you're not a beneficiary to be, about the state's covered services and eligibility categories. And it's also usually the first place where many of your students and their families would look for information. State education departments and state Medicaid agencies, state behavioral health or mental health departments are also regularly engaging now in partnerships to help share information like this and other useful resources related to the implementation of school mental health services with all of the LEAs in your community and beyond. Our website makes reference to many of those resources that you'll see them circulating. So if you sign up for our listserv, as Kelly alluded to earlier, you'll regularly see some of those highlighted also. But be the advocate. I would encourage you to circulate this information yourself to anyone you think can find it useful. All right, another question from Ruth. Our school system is currently already a Medicaid provider. Kudos for you. To do the manual you're working with, only LCSWs, licensed clinical social workers, can be reimbursed for mental health counseling services. Very good. So this is a question that I think I probably want to hold off answering for today, Ruth, forgive me. In our December 13th webinar, part 2 of this series, we'll be talking a lot about the third and fourth conditions for Medicaid coverage or payment for services, including whether providers are Medicaid certified providers. They are the providers that the state Medicaid program has listed as the providers who can actually bill for these services. So I hold on to your question. Please bring it back on December 13th. I really appreciate it. Question from Deanna. When doing telehealth medical appointments in school, we found we could not do them at school if parents did not have transportation. Transportation is provided for child and parent to the center, but not for the parent to school. Okay, so if I'm understanding your question, Deanna, sometimes in many districts, telehealth services, the originating site for that service is not the school, and it may not be the home that is considered acceptable in the state. It might be a certified telehealth care center or an FQHC or some other healthcare setting where it is allowed for telehealth services to originate. And in those circumstances, yeah, it might be that the state also requires that there be some means of transportation in place to make sure that the individual can get to that site of service and meet that requirement. That does happen, and it is one of the ways in which I think telehealth policy is likely to change over time. As I alluded to in some of my comments earlier, telehealth is expanding continuously these days. Many states are finding new ways to expand coverage and payment for telehealth services. And this might be one of those cases, Deanna, where your state is seeking, or providers in the state are seeking changes in the Medicaid program where the originating site can be the school, or it can be the home, or it can be flexible about these different arrangements so that the transportation requirement is no longer important. It's moot, right, at that point. I hope that's the case, and I hope that's helpful in answering your question and addressing your concern. Please feel free to follow up with us if there's anything else we can help clarify related to this issue. Oh, thank you, Kelly. I appreciate you adding into the chat the link to our website where additional resources can be highlighted, including the opportunity to join our listserv. Please do circulate that to all your friends and colleagues. And I see a question from Stephanie. Hi, Stephanie. The AMA created CPT codes, but they are not the regulatory body for Title 42 public health, correct? Is there a way to determine the federal regulations that guides the implementation practices of the CPT codes? So first, I want to clarify a couple of acronyms here. The AMA is the American Medical Association. They have a body, several bodies actually, that are involved with CMS in determining what are services, what counts as providing a service, and what is billable. Including setting standards for CPT codes. These are current procedure terminology codes, which you have to use in your billing records. So then Stephanie's question is, the AMA is or is not the regulatory body for Title 42 and public health and Medicaid, correct? Well, so the AMA certainly had, and state medical boards certainly have plenty of influence with Medicare and Medicaid and other state insurance regulatory bodies governing what services can and can't be covered under what conditions. So are they the regulatory body? No, but they certainly have some influence on that process in certain instances more than others. Is there a way to determine the federal regulation that guides the implementation practices of the CPT codes? Well, there are certain federal regulations and guidance around what counts as mandatory services and what counts as optional services, how they define those categories, and the services, the CPT codes that fall within them. So in some sense, the federal regulations that exist related to mandatory and optional services do guide the implementation practices of CPT codes. They provide some boundaries around which states can operate when setting their standards, requirements, and terms. And certainly, when the federal government establishes that certain services have to be provided under certain conditions, maybe certain settings are ruled out, right? It makes it harder for some states to make certain settings eligible just based on how certain services are defined. So, is there a way to determine what are the federal regulations? Well, I would certainly look at the mandatory and optional services guidelines, which are very plain on the Medicaid.gov website. And would be listed, I think, in pretty plain terms in your state plan for your states. Stephanie, since you and I have some familiarity with one another, I know you work in multiple states. The state plan for each of the states that you work with should have some distinct information about what services are covered, and they may reference certain federal regulations that define these terms in them. If not, I expect that the offices that govern state plans and state plan amendments within CMS would be a good resource to look to. All right, I'm looking at the clock and our chat here. We might have time for one more question if somebody wants to add one in the chat, but I certainly also want to take this opportunity to remind you all how much we appreciate your feedback on our webinars and events and resources. The best way to do it is to click the link in the chat here to fill out our GIPRA form, which is again required by our federal funder, SAMHSA. And then there is also that secondary link. There will be that secondary link that will automatically pop up to answer some additional questions for us in Qualtrics, and we really appreciate your input in both of these forms. Again, fill out the second one if you're interested in receiving a certificate of attendance for your participation today. And then in a few days, I believe you should expect to receive an email thanking you for your participation in our webinar today and including links to the recording from this webinar and the slides. And of course, reminding you to come back on December 13th for part 2 of this webinar series, where we'll talk more about the other 2 requirements related to providers and settings. Thank you all again for your participation. I'll hang around for a few more minutes if there are more questions, but barring that, Kelly, we can probably cut the recording here, and thank you all.